to present an overview of our current projects. We do a lot of very broad work. Health workforce policy and research is very broad, so I'm not going to be able to go deep on specific projects. I would look forward to engaging with anybody that wants to have one-on-one time or like team time discussion on any of our projects or lines of inquiry. Happy to follow up with you all. And so that's kind of the landscape of where we're headed. So I'm going to start with defining health workforce policy. And I never want to assume that the audience I'm speaking to would define policy the same way that I do. So I'm going to take a minute and make sure that we're all on the same page. When I am saying I am a health workforce policy researcher, what does that mean? There are broadly 3 types of policy. Now, we could say that each of these areas have many different types of policies within them. But when I speak about health workforce policy, I generally organize that conversation into 3 focus areas. One of those is governmental policy. That's probably what most of us think about when we think about policy, okay? That includes legislative policies, and we're going to go through these and kind of talk more about them, and administrative policies. Anything governmental, federal government, state government, even local government. That would be governmental policies that impact, affect, define the workforce, the environment they work in, et cetera. There are also broadly what I will say as education policy environment. And I want to share, the slides are not all inclusive. I could give probably I could teach a whole course just on health workforce policy. So we're going to be just touching on different areas. But education policy is a huge area of policy that impacts the health workforce. The top policy that we can think of is accreditation of education programs. So I think we have some healthcare professionals in the room with us today, whether you're a physician, a dentist, a registered nurse, a pharmacist, et cetera. You went to a program likely that had to be accredited because that's a requirement in order for you to complete your degree and actually become licensed to engage in practice, ultimately to be able to provide patient care, okay? So the policies that shape education, very frequently they can be governmental, but they're actually mostly non-governmental. And that's when we think of accreditation agencies. So the AAMC, nursing has their accreditation. All of the health professions programs have their own accreditation, education accreditation entities. The last area, and I struggle with what to title this area, I just titled it organizational, and we can have more conversation about that. But these are all of the policies that are not governmental, and they are not educational. They're not the education regulation or environment. These would be organizations such as providers, health systems, their policies. It includes any type of organizational policies. So even professional association policies, all of those do have an impact and influence the workforce. So I want to spend a few moments talking about each of those areas. And the first, which I think probably most of us are the most familiar with, although I'm not going to assume that, I know some of you guys probably are organizational policy researchers, is governmental policy. And government policy at the very base level can be broken down into 2 things, legislative or administrative. Legislative policy is what we think of when we think of the Indiana General Assembly meeting. They look at bills, they go to committee, they hear on the bills. Some of the bills get passed, signed by the governor, they go into law. That's legislative policy in the state. The federal level, it's just, at the federal level, but the same thing, legislative bills are presented, they go through Congress. If they're enacted, they become law. And so that's legislative policy. Legislative policy has 2 primary levers, okay? 2 primary ways in which those legislative policy can impact the workforce. The first is through regulation, regulating some aspect of healthcare delivery or of the workforce, okay? An example of legislative policy that directly impacts the workforce and is very easy to understand is our statutes, our law as a state regarding licensing of physicians, nurses. I still hold my dental hygiene license. That is in statute, the licensure requirements, those base requirements, okay? So that is regulation. That is law that regulates the workforce. There are many different types of regulations that legislative policy can enact. Also, very importantly, something we are all very familiar with is appropriation, right? So legislatures can appropriate or regulate. Appropriation is the taking of the budget, taxpayer dollars, and appropriating it for different uses and funds, okay? So when we're hearing about the federal budget, that's going through budgeting and appropriations and determining how those funds are appropriated, including for health services research, okay? So government, whether it's federal or state, they either enact policies and laws to regulate some aspect of the workforce or healthcare delivery, or they appropriate it. Now, that's legislative policy. There's also administrative policy. Legislative policy is the realm of state legislatures, general assemblies of Congress at the federal level, okay? Administrative policy is the action and the policy-making capability of the executive branch. So governors, the president, and all of the agencies within the executive branch. So administrative policy here in Indiana includes any policies or provisions that our executive branch agencies or programs design and put in place. So rules they may define that would impact the way health professionals can practice. Legislative policy defines a state license. Administrative policy is made by a licensing board. So the State Board of Medicine, State Board of Dentistry, that board is a part of the executive branch. They get to also make policy. Those policies are administrative policies. That's only one aspect of administrative policy. The way our Medicaid program is determined, the funding, the provisions, that is also administrative policy. So rate setting, all of those things fall into administrative policy. And you can see now there are a lot of legislative and administrative policies that directly impact the workforce, whether it's through regulation or appropriation or programmatic decision making. So one big hot topic in healthcare is like, how do we incentivize health workers to go into areas of need like rural communities or serve marginalized or underserved populations? Sometimes we operate incentive programs like loan repayment, like scholarships. Those are typically defined, those programs, the requirements for them, the metrics for them, those are defined in administrative policy. So that's all governmental policy. I touched on this briefly, but education policy, the top one that I can think of, and I want to share with you all, I am an expert in governmental policy. So that is my deep area of focus. But these other areas are critically important, and I have more like broad-based knowledge on it. Some of you in the room may have very deep knowledge on education policies. So I spoke about accreditation. One aspect of program accreditation, like let's think through that, okay? For our medical residencies, I know probably many of us look at certain types of health services that may be delivered by certain healthcare providers, maybe specialists, maybe residents are trained in those. There are policy provisions regarding the specific procedures medical residents have to complete while they're in residency, including how many of those very specific procedures they have to complete in order to comply with and satisfy the requirements of their medical residency. Those are policies. That is a very good example of an education policy that shapes the workforce. It shapes what the workforce is prepared to do. That is policy. and that is education policy. Organizational policy, I'm going to use the term little p. Some people don't like that being called little p policy, but when I think of policy, I think of government policy, okay, right? And so when I say little p policy that shapes the practice environment, I'm talking about all of those, the other policies within the context that the healthcare workforce works, provides services, engages with patients and communities that impacts their practice, okay? So these little p organizational policies, they can even be something as simple as hiring or contracting policies that healthcare provider or health system organizations can have. They also can include practice models. So the way in which a health service organization would design their service line for a certain type of medical care or healthcare services and enact that model across their whole health system and all of their campuses and clinical settings, that is a little p policy because it doesn't impact the environment of everybody in the United States or everybody in Indiana, but it is a policy that impacts the way the workforce is delivering care within an organization, within a community, within a setting, okay? So those are organizational policies. So I've defined policy. I've shared with you the 3 areas that I conceptualize for health workforce policy. Now I want to talk for a minute about health workforce research, okay? I define health workforce research as an applied field of study focused on how health workforce policies impact health services and outcomes, and specifically how they impact availability of care, accessibility of the care that is there, quality of the services, and then ultimately, of course, the costs of those services. So I know we talked through the different policy areas, but I want to take a moment and just talk through different aspects of health workforce research and how we work on them, like what those are. The first is regulation. I know I shared with you that regulation is a policy function of government, okay? But examples of regulations that directly impact the healthcare workforce and how the workforce can actually be engaged in health service delivery within a community. Health professional licensing is probably one of the top forms of health workforce policy regulation that impacts the workforce, okay? If you are in a health profession that is required to have a license to practice, you have to have that license. You have to satisfy the requirements that the state has for that license. And then you have to maintain that license in order to be able to engage in health service delivery, okay? And so that is occupational regulation. And I'm gonna back up for 1 minute. And I just wanna make sure everybody's on the same page. In the division of responsibilities between the federal government and the state government, states have the power and authority to regulate occupations. The federal government has no jurisdiction over that. So I just wanted to share that. So each state is its own occupational regulation environment, and that is the licensing requirements, the supervision requirements. So does the profession need to be supervised by another professional with another license? The scope of practice or the scope of services. So what specific services can a person do if they hold this license? All of that is defined in state policy, both legislative policy and administrative policy. This is very important if you engage in any national research where you are looking at data at the state level, because occupational regulation varies by state. State legislatures and state boards have the autonomy and authority to regulate however they see fit. And so that is a very critical, important distinction that completely shapes the way in which the healthcare workforce can engage in health service delivery and provide services. I personally know this, and actually the whole reason I went into this field, which I would say is kind of an emerging area because we don't have a lot of health workforce researchers, is because I am a dental hygienist. Now, I have not practiced since '09. Don't worry, I'm not going to get scalers out and try to scale your teeth. I will not do that to you. Those days are done, but I do maintain my license and my CE. I was a dental hygienist here in Indiana back 2000 to 2009. At that time, Indiana's state licensing laws for dental hygiene were very limiting. A dental hygienist who has satisfied national education accreditation requirements, graduates from an accredited program, becomes licensed, and by the way, dental hygiene and dentistry in Indiana is still required to do live patient state examination, which means you actually have to find a patient and bring them down to Indianapolis and actually do procedures physically in person and get them checked to get your license, okay? And so back in 2000 to 2009, Indiana's occupational regulation environment was very limiting. I had grown up with a grandfather who was a dentist in Denver, Colorado. I spent my summers visiting them. I would work in the office. I was very familiar with dental hygienists being able to provide dental cleanings, operate pediatric dental cleaning offices, work within the school districts. In Indiana at that time, dental hygienists had no ability to do any services independently outside of the general and direct supervision of a dentist. Not even providing fluoride, which I think we're probably mostly familiar with, not even providing fluoride for children, for high-risk children in schools without a dentist prescribing it. That was the practice environment at that time. That's how I became really interested and started understanding regulation and the impact that regulation has at the state level on how the workforce can even deliver care, okay? So occupational regulation, critically important. I'm just going to quickly touch on two examples of regulation that's really pertinent right now. One is interstate licensure compacts. So I shared with you guys that each state has the autonomy and authority to license and define what the licensure requirements are, and how those will be enacted within their state. That is a challenge, right? Because we are increasingly a mobile society. And if you live, down in southern Indiana on the border of Kentucky by Louisville, or you live in Gary or Hammond right across the state line from Chicago, there's a lot of workforce mobility across state lines, not to even think about telehealth, okay? And the way telehealth has opened up the ability for licensed health professionals to provide care and services to patients at great distances. However, state licensing still applies. Wherever the patient is located, the professional has to be licensed and credentialed to be able to deliver services. One of the big policy initiatives to help, especially with telehealth, professionals to be able to go into different states and provide services and have licensing authority is interstate licensure compacts. And so that is where states enact the same law to agree upon, I will let you from Indiana come into Kentucky and practice nursing under an interstate licensure compact. That is a really hot policy, legislative policy that has been sweeping the states. I'm going to just share with you guys that is a ripe area for research because I am working on a study for that now, but there's a lot of conversation, especially with our rural and frontier states in the United States. We enacted all these licensure compacts so that we could have professionals come into our state easier because it helps with interstate mobility. But if you are a rural or frontier state that has beautiful landscapes and outdoor environments, but you offer interstate mobility and you can have professionals locate in your beautiful state and provide telehealth services in different markets in other states under a compact, getting more health professionals into your state does not mean you're actually increasing patient care access for patients in your state. If anybody here is interested in talking about licensure compacts, I would love to follow up with you. This is a very, very important area. And my theory is that we saw many states enact licensure compacts and that we are possibly going to see a massive retraction across the states in the next decade, because I actually don't think it's helping the access issues in some states. Okay, so that's just a regulatory example of health workforce policy research on regulation. Education research, I have a colleague here who worked for our IPE center, interprofessional education, the policies related to education programs for health professionals, engaging in interprofessional education and clinical experiences. That's an education policy. Obviously, evaluation of those policies, the outcomes of those policies, that is a form of health workforce policy research. Practice, health workforce practice research. This is a very broad area. Our team at the Bowen Center, we do a lot of this. Sometimes it's just descriptive research, looking at the geographic distribution of the workforce across the state, across communities. Maybe not just the distribution of the workforce, but maybe the workforce that is engaged in providing services to Medicaid enrolled individuals. And maybe even further, the workforce in certain communities providing services to Medicaid enrolled individuals that are also engaged in labor and delivery services. So that is an example of looking at the geographic distribution of the workforce and what type of services they're providing for the communities that they're in. That's a very basic applied form of research, but it's absolutely critical to inform workforce development initiatives within a state or community. Reimbursement research is also a big area in health workforce policy research. So rate setting. How are rates determined for certain services and the reimbursement of those services? That is an applied form of research. Medicaid offices and programs at the state level are dependent upon applied researchers and actuarial scientists that actually do those analyses that inform rate setting within the states. Workforce projections are another big area. I get asked more than any other question, could you help us understand how many, family medicine physicians we're going to need for our rural counties by 2030? I'm just going to share with you guys, there is no silver bullet to workforce projections, okay? Because all of the projection models for how many healthcare workers of what type we were going to need in the United States, in each state, in local communities, I'm going to tell you that COVID-19 completely blew up every single projection model. And I'm also going to share with you that if you go on and you start searching healthcare workforce projections, like physicians, how many physicians will we need by 2030? How many registered nurses will we need by 2030? There are a ton of models out there. The federal government has models. You can look at HRSA's models, the AAMC, the American Academy of Medical Colleges. They've got projection models. All of them are different because they're all built on different assumptions. My personal thought is that the actual truth lies somewhere in the middle and is completely dependent upon the chaos in the environment, okay? So that is an applied form of research, and there are a lot of folks and research teams that work on workforce projections, but there's a lot of limitations to each of those models. And as an applied health workforce policy researcher, I get all of the projection models and look across all of them and understand all of the assumptions that each of them used, and then try to look at what the middle point would be and say that that's a trajectory to shoot for. So the final area of health workforce research is administrative decision support. And when I use this term, a really great example of this is health systems determining how and when they would expand into market areas, and looking at what the workforce needs are and the health service needs are in certain communities that they might be able to fill. Workforce data is a key part of that type of administrative decision support. That's just one example. There are many. Okay, I'm going to take a beat. Does anybody have any questions before I go on and talk about the Bowen Center? Yes.
This is really great, and I appreciate it. Where in this taxonomy does payer policy fall? You know, Blue Cross Blue Shield, and, you know, has certain rules that it applies, or policy for what it will pay for and when it will pay for it, et cetera. Often based on CMS rules, but not always, and they change over time. But what was experimental is now not experimental. That doesn't really fall in governmental. It doesn't fall in any of the three categories you get there. And yet, if it's not paid for, it ain't going to happen. A good example is community health workers. You know, you couldn't pay for them before. Now you can pay for them in certain conditions, et cetera, which hamstrings how they're used. And yet, I practiced primary care for 25 years. Most of what I did, half what I did could be done by a community health worker. It didn't take me. And yet they didn't pay for them back then, so I had to do it all. So where does that fall? And how does it integrate with the rest of it?
Thank you for asking that question. So I'm going to answer it, and it's going to take a minute, but I think that this will be helpful. Probably other people have this question too. I shared with you big bucket areas, right? Governmental policy, education policy, organizational policy. What Dr. Tierney was asking about is, well, what about commercial insurers, right? I think that's what you're getting to. What about commercial insurers and their reimbursement, how they're reimbursing services and their determinations? In many cases, they align with CMS, Centers for Medicaid and Medicare Services, but not all the time, okay? So I shared those three bucket areas, but in reality, it's pretty much like a Venn diagram, okay? And so that's what I was saying. I could teach an entire course on this. And I hate kind of throwing all this information at you. But it's really a Venn diagram. Commercial insurers are regulated, okay? They are regulated. Commercial insurers and I'm sorry guys if this is too technical, in commercial insurance, there is commercial insurance that's available to folks and generally available to smaller businesses. And then there is self-funded insurance that is self-funded insurance plans that are actually operated by or administered by commercial insurance. Here at Indiana University, I know you guys are Regenstrief, but IU, and I know you're enmeshed. Indiana University, big employers. So most of the employers that we think of have what is called self-funded health plans, okay? And so I am faculty at IU. I've got my insurance card. It says Blue Cross Blue Shield. Blue Cross Blue Shield is administering my insurance, but Indiana University has a self-funded insurance plan. Indiana University's self-funded insurance plan is actually regulated by the federal government through ERISA. Other commercial insurance plans for smaller companies that buy into commercial health insurance and individuals that buy marketplace plans directly with commercial insurance, that is regulated by the Department of Insurance in the state of Indiana, okay? And so the question you're asking is super complex, and it varies based on what type of plan and whether it's self-funded or not. And that's where really digging into this, like, it would require a deep conversation. At the end of the day, our work and my expertise focuses on the health workforce. And you're absolutely right. We can all sit around and kumbaya, and they're very mission-oriented. I'm very mission-oriented, guys, okay? But the reality is we all have to eat, and our families have to eat, and some of us have to pay a lot of student loans back, even though we're paying for our kids' college, okay? And so we do have to be able to make a living, right? And so there has to be reimbursement. And what gets reimbursed is what gets provided. And so that's a great question, Dr. Tierney, and maybe we could follow up on that. But it is very complex, and it just goes to, it's a Venn diagram. I shared them as buckets, but it truly is a Venn diagram. Okay, so I'm going to go through this pretty quickly because I want to make sure we get through all the slides, and then we can open it up for questions. And I'm going to be hanging out for a while if anybody wants to chat. The Bowen Center, what is it? Okay. We had a governor in Indiana. I think it was 1971 to 1981 or something like that. And I apologize if I'm wrong and somebody knows. His name was Otis Bowen. He also happened to be a family medicine physician from North Central Indiana in a rural community, which is close to my hometown. And he was actually a chairman of the Department of Family Medicine here at Indiana University as well. For a period, he was appointed by the President of the United States to be the Secretary of Health and Human Services at the federal level. I am appointed in the Department of Family Medicine, and the Bowen Center for Health Workforce Research and Policy is a center housed in the Department of Family Medicine named in honor of former governor, the late governor, he passed away, Dr. Otis Bowen, okay? The center was originally established under the name the Bowen Research Center in the 90s. At that time, it very heavily focused on family medicine education research. When I joined the faculty in 2014, I was recruited in, and I had a very specific interest in health workforce policy and research. And I was charged with help us create a health workforce policy research center. The Bowen Center had lost leadership. In 2015, we went through an approval process with the then Dean Brader, to do a formal rename of the Bowen Center to the Bowen Center for Health Workforce Research and Policy. So the Bowen Center has existed in its current state under its current mission since 2015. I am extremely proud of the work that we've done. It is a very applied field. And so I am just going to say it's been really hard to move the chains and get people to recognize that the work we're doing is very valuable, but it has become increasingly valuable as the applied research and work we're doing is actually tangibly informing legislative policy and administrative policy and organizational policy in ways that we are now able to measure outcomes. So the Bowen Center here at IU has become very recognized nationally as a state academic best practice for applied health workforce policy research. And I am extremely proud of the work that we're doing. This is about us. You can go to the website if you want more information. I'm not going to take any time to go through that. This is our team. I'm joined today. I know I'm the talker, but I'm joined today by the people sitting over there that are fabulous researchers. Dr. Brittany Dalton, Associate Director of the Bowen Center. Sierra Vaughn is our Assistant Director of Data and Research. If you're interested in data and the data we steward, Sierra would be your person. The rest of our team is up there. We would be happy to meet with you. We have an Assistant Director of Policy and Strategy who oversees our policy research portfolio that I'm going to talk about too. At the Bowen Center, we have 3 focus areas. One of them is data stewardship. I'm going to talk more about that. The other is policy expertise. And then finally, of course, service and research. So I'm going to go through those areas quickly. Regarding data stewardship, our team at the Bowen Center works very closely with the state of Indiana. We do have a line item that supports a scope of work. It's administered through the Department of Health, where we support the state of Indiana with health workforce data collection, management, and reporting for state regulated or state licensed healthcare professionals. And so this is the life cycle of our data stewardship, and I'm going to go through each of those quickly. One of the big innovations that the Bowen Center has done in Indiana that other states are seeking to replicate is the collection of workforce information from licensed healthcare professionals when they renew their licenses every biennium. So remember we talked about occupational regulations, state licenses. If you hold a state license in the state of Indiana, you are required to renew it every 2 years and keep it active, or you are no longer able to practice within the state. That means every 2 years, every single physician, every single nurse that has a license that enables them to provide care and services in Indiana has to engage with state government. That engagement to renew their license is a strategic opportunity to get information to say, hey, are you still practicing in our state? Are you seeing patients in Indiana? Great, you are. Where are you seeing patients? Are you seeing in Hamilton County, Marion County, you in Scott County? Where are you providing care? By the way, who are you providing care to? Are you seeing prenatal patients? Are you seeing pediatric patients? Are you seeing patients with substance use disorder? Indiana has implemented workforce data collection at the time of license renewal now for all licensed, state licensed and regulated healthcare workers. That includes everything from physician down to CNA, and we are incredibly proud of that. In 2018, Indiana passed a law that requires certain licensed professionals to provide that data. So it was voluntary elective when you renew your license, beginning in 2019. Now, when licensees renew their license every 2 years and you do it through the web-based portal, through the licensing agency, you cannot pass go and renew your license until you respond to those questions. Our team is the research entity that helped to create the surveys, inform the law, and now we help support basically what happens with that data after it's collected. That was just an example of the survey questions. There are fixed survey questions that are not changed biennia to biennia, because you guys are researchers here, so we can't have surveys that change, right? We need to be able to make sure we're collecting cross sections of the same thing every 2 years from the workforce. Our team does work with state government on minor adjustments to those questions and response options each biennium in response to government, state government priorities. So for example, during, I would say we're still in an opioid epidemic. I don't know that we'll ever be out of it, but when that was a top priority of the administration, certain response options were captured from licensed professionals to find out which professionals were engaged in providing services to individuals with opioid use disorder. So that's just an example of a minor change to the survey that occurred. So we work with state government to make sure those surveys are stewarded and that the integrity of the data collection is maintained biennia to biennia. After a renewal period for a profession is closed, and in Indiana, if you hold a license, everybody doesn't renew at the same time, okay? So it's not like, you know, everybody, nurses, dentists, doctors, pharmacists, they don't all renew the same time every 2 years. Each profession has a quarter, a calendar year quarter, in which they renew across the biennium. So some professions like medicine and registered nursing, I think they're Q3 of odd years. Dentistry, dental hygiene is Q1, I'm making this up, don't quote me on this, Q1 of even years, okay? And so it's pretty complex because there's constantly new data being captured as we go across the 2-year biennia. Our team works with state government after the renewals close, after a certain period, because there are laggards, you get a 30-day grace period, and so some people don't renew their license until the 30-day mark after it actually closes. Those data are extracted and our team manages those data. We have cleaning and coding protocols, addresses are geocoded, and then those data are prepared and stored, and we start cranking out reporting on the data, descriptive reporting. That includes data reports, which are basically technical workforce supply reports for the state of Indiana. How many licensees do we have? How many in each specialty? How many report that they're actively engaged in practicing? How many in each county? How many hours in direct patient care, et cetera? All of that is reported there. In addition to large technical reports that probably very few people read. We do more accessible handouts. These infographic handouts those are what are more commonly used by policymakers, okay? It is not uncommon for a committee at the Indiana State House that's hearing on a bill related to nursing or medicine or maternity care services to actually have a one-pager from our team with information on the workforce as they're discussing the bill that they're considering, okay? So we do technical reports. We also do very accessible one-pagers and briefs that summarize the descriptive data. We do have a dashboard that's available as well. We're very proud of our dashboards. They are an attempt to open source data at the aggregate level to any individuals that need access to it. These dashboards enable folks to select and look at the geographic distribution of professionals by specialty, by setting, if you are interested, we would be happy to connect and walk you through using it, even by services that they report providing geographically. So this is incredibly powerful data. I can share with you that other states are right now trying to replicate this. Within the last year alone, I've had 3 different big institutions consult in their own state to say, how can we become the Bowen Center for our government here? And some of them are Big 10 institutions that are working to do that. But this dashboard is publicly accessible. If you're doing health services research and the workforce is a part of that, I would encourage you to check those out so that you can see what type of data we actually have here in Indiana to support research and analyses. I'm going to go really quickly through our policy expertise and our projects. In addition to our data stewardship, I am a policy researcher. I actually was the first graduate from Fairbanks in the HPM Health Policy and Management program. I'm very proud of that. This is basically our methodological approach to policy research. And if you're interested in that, I will follow up with you. We can chat about it. But the outcomes of our policy research, again, remember, I primarily look at governmental policies. And actually, my deep expertise is state policy. So I am pretty much a state health workforce policy research expert, possibly one of the most focused researchers in that specific area. There's only a handful of people that have that expertise. What that means is a lot of my research studies look at how states have enacted laws, including the very specific legal or statutory language that is used in each state regarding a health workforce, a health profession, a health service delivery approach that impacts the workforce, and then capturing that data as qualitative information and categorizing it and coding it to basically perform research to understand the variations across state environments and policy, okay? And so this is just an example of a study that we're working on right now that is looking at the way in which states have enacted new occupational regulation for behavioral health paraprofessionals. I've had some conversations with folks about community health workers. I'm just gonna tell you, this study is only looking at behavioral health paraprofessionals where that profession is solely focused on behavioral health. We know a lot of community health workers are engaged in behavioral health services. I would love to follow up with anyone that wants to talk about the behavioral health paraprofessional study though. It is a national study and we are bringing folks together from across the US in July to review the findings of that study and talk about a framework for state policy action across the 50 states to formalize a whole new workforce of paraprofessionals in behavioral health, all trained below a bachelor's degree. So that's the focus of that program. But that's an example. In addition to policy research expertise, we do policy monitoring. So our team monitors all of the legislation as it goes through the Indiana legislative process here during our session. We have a dashboard where you can actually follow bills week to week, and we update them after committee hearings, which bills moved through committee, which bills died. we have a specific emphasis on health workforce related bills, either directly impacting the workforce or indirectly impacting the workforce. And then we also monitor health care bills generally, but with a specific, really deep focus on the healthcare workforce. During the legislative session, our team will also take the data that we steward and prepare custom one-pagers for specific bills. So in the instance that a piece of legislation is looking at, I'm making this up, guys. A piece of legislation is looking at how can we get more family physicians into Indiana rural communities and encourage them to receive training and engage in labor and delivery services, because we know we don't have obstetricians in rural Indiana, okay? So let's say that there's a bill that's focused on a strategy for that. Our team then goes into our data warehouse. We pull data on what is the current distribution of obstetricians, what is the current distribution of family physicians that report providing labor and delivery services, and we package custom one-pagers or data briefs that we send to all of the committee at least the day before the hearing. So that is a very tangible way that we are translating data into actionable information for policy discussions pretty much in real time. This is the dashboard. If you're interested, I would encourage you to check it out. Obviously, session ended, but you can get on our listserv and next year get notifications when the Bowen biweekly bill brief goes out. Okay, I'm just going to round us out with some of our studies. So what I shared is I shared about our data stewardship. I shared about our policy expertise. Obviously, we do a lot of research, a lot of service-related research. These are just some big ones that we've done. We worked with the Indianapolis VA Veterans Affairs Medical Center on an analysis and an evaluation of their contributions to clinical training of Indiana's healthcare workforce. That looked at how many of our licensed health professionals are we able to quantify did some of their training and touched the Indianapolis VAMC during their clinical training. We know there are a lot of clinical training partnerships with the VA. And so we were able to work with them and their education partners to do a quantification of the impact of VA clinical training on Indiana's workforce development. We also did a economic analysis to say what is the cost contribution of that clinical training, which if you're engaged in clinical training, you know that it takes a lot of time for healthcare professionals to actually engage in and provide that clinical experience and training to students. And so we actually worked with them to quantify the cost contribution and economic value of that. I would encourage you to check that out. This report was shared with Congress, and I am aware that they have received funding for a new VA hospital, I believe, and this report was cited in committee hearings on that. We have worked with the state of Indiana on an EMS workforce assessment, and we have implemented workforce data collection on all types of state-regulated EMS professionals. We worked on behavioral health and mental health studies, and very recently we completed a medical education pipeline to practice study that looked at Indiana's medical schools, retention in our medical schools into Indiana residencies, and then looked at our residency composition and then retention of our residents into state, into practice, into communities of need. And that included a policy review and research as well. We publish papers because we should and we have to, but our capital is informing policy. So to me, no amount of having my paper cited is going to be more effective than having the research I've done, heard in a committee, informing a new law that extends access to care, improves availability of services, et cetera. So this is just a sampling of our papers. So I'm going to leave you with the variable health workforce policy. It's no longer hidden. I'm really looking forward to engaging with you guys. I'm sorry I talked so long. There's only 5 minutes left, but I'm happy to stay around and chat and take any questions that you might have. I hope that this has been helpful for you to understand health workforce policy and research. This was truly just a gloss over the area and the field. We are willing and available and ready to partner, to connect with you all, to answer questions, even to consult if you're working on a study and after hearing this, you're like, you know what, I probably better understand if my data set might have some variation that could have to do with state policy. That is exactly what I do consultations with, just even discussing it all the time with different researchers. And I'm doing that like across the US with researchers. So I'm happy to be doing that here in our own institution. So happy to take any questions or just even hang around and do one-on-one if people want to chat.
Well, thank you for that fantastic presentation. Just a lot of material to think about and a lot of research and opportunities for impact with policy. So thank you. I don't know if this is working. I'll try to project. So to start the asking questions about primary care, there are policy level concerns about the proportion of healthcare resources that go towards primary care. Newsflash. And my understanding is there's not a lot of federal policy action, but there's a fair amount of state level policy action as of late. Specifically, I believe a number of states are starting to track the proportion of healthcare spending at least attributable to the state that goes to primary care versus other services. And some states are going so far as to set goals and targets for that over time. And so to put some enforcement into the tracking. So I was just interested regarding your awareness regarding this type of policy activity in our state, or how the type of data or services that you provide could inform those types of discussions.
Thank you for that question. So regarding any type of state action here in Indiana to explore the distribution of our, I would say, let's say state-sponsored programs, our public insurance programs, what distribution, what share of services and what cost is going to primary care versus specialty care. I am not aware of a study that is ongoing in Indiana. Maybe somebody else is in the room on that. I am not aware of that. I am aware that that is a discussion nationally, and I am aware of the changing landscape of primary care delivery with regards to the workforce. So, and that might be, and that can be an offline conversation. So basically the composition of the professional care team that is delivering primary care services. For many years, it's been the family physician, out in the community. And over the last several decades, we've seen the increase in, I hate calling like advanced practice providers. So our advanced practice registered nurses, our physician assistants in primary care delivery. State policy impacts the extent to which those workforce models can be employed and deployed to deliver primary care services. I think there are studies that show that certain workforce models and approaches can actually help reduce cost of primary care delivery. So I'd be happy to follow up with you on that. Yeah.
I assume that the stuff you do for government is done by, I'm getting into how it's paid for. So that's done by contracts with them. Are they, you have a long-term contract with them with an agreement of what projects to do, or are they short-term individual snowballs they throw at you and you can catch their drop?
Thank you for asking that. So our data stewardship and our policy expertise are a long-term contract. That is a long-term contract that we have through the state, and that is funded through a line item. The projects, the larger projects we have are one-off requested projects that are additional scopes, sometimes added on to our contract through amendment, sometimes completely separate new contracts with the state.
Okay, good. The second question is, who funds the research? Is it consistent enough that you've been able to maintain it? I mean, if you do research, but the projects are either big or little bit, they come in intermittently, it's hard to maintain a core personnel within your center. So how is that done?
So, and I apologize, maybe, is everybody interested in that? Because I know we're at time. So I'm going to answer that question, but I don't want people to feel bad. If you got to go somewhere, feel free to get up and go. So we have a line item in the state budget. It's administered through the Department of Health. It has our core funding for data stewardship and policy expertise. That funds, I would say, 50 to 60% of our team. The remainder of our work is based on grants and contracts external. So we have to hustle it just like everybody else for that. We have been very fortunate over the last, I would say, 5 years that I think we started out and it was, really trying to establish what we were doing and earn credibility. But now, especially since COVID, when everyone was talking about the shortages of healthcare workers and the need for workforce solutions and policies that encourage development, retention, recruitment, et cetera, we have actually had increasing sponsorship through large philanthropic organizations, both in the state and nationally. And those have been consistent, where those national philanthropic organizations will actually come back and solicit additional lines of inquiry. So our core team is 50 to 60% funded through that primary state contract. Our research, are some of those reports that I shared with you, the research and most of our papers. I'm just going to share with you guys. Most of our publications are labors of love, okay? Because we are funded to do applied work, produce reports, produce policy analyses, produce, policy relevant materials. But I'm going to share with you guys, we got to publish, we know this. So those papers that we shared, most of them, with the exception of some new and emerging areas where people are actually coming just to fund research through our team, that's labors of love to translate our applied research into scholarly contributions in peer-reviewed journals. So, we're having to build credibility and hustle it with our lines of inquiry. So,
Thanks.
yep. Okay. I think we're past time. Yeah. Thank you, everybody, for joining.